So one of the things, Kevin, that you and I have really been uh, directing our attention towards is children in the primary dentition and the early mixed dentition. So for your primary interventions under 6 and my primary interventions for under 8. As a pediatric specialist and myself as a primary care general dentist, we have historically been directed by the orthodontic standard of care to treating much later in the permanent dentition. In teenagers of the, after the 13-year-old canines have come through. I wanted to explore a little bit about why there was a shift from the first 100 years of orthodontic practice, from treating the entire age range of children, teenagers, and adults, to just obsessing about teenage alignment. I suspect that in the later half of last century, there was a big drive to try to verify through evidence bases our ability to correct skeletal malocclusion. We ran enormously expensive and wide-ranging randomized control trials that were published after often 10 or more years of research and development in multi-centers. The two pivotal ones were from Tulloch and Profit in 2004, and then later on O'Brien in 2009. And they basically looked at how effective functional appliances were for class 2 division 1 malocclusions, and compared it to what we call a one-phase treatment, which is just fixed braces, in comparison to 2 phases treatment, where we would try to get skeletal change in the mixed dentition and then later tidy up in the permanent dentition. The outcomes of these decade-long studies, level 1 evidence, randomized control trials, was that we actually have no influence on skeletal growth using functional appliances. And that, in fact, the children benefited more from a shorter and less invasive treatment if they were just treated in the late part of their growth and development, which is permanent dentition. As we were moving into this concept of evidence-based dentistry, that became the new boundary. We were effectively told, don't waste your time trying to modify growth. Growth is effectively genetic based, and that it makes the most sense just to put the fixed braces on at 13. We used this in the last generation of orthodontic care as the foundation. And so those of us who work with younger children are frowned upon. And I wanted to recognize the immense amount of time, money, and energy that was put into these trials, and why they categorically showed functional appliances do not change skeletal growth pattern. But I also wanted to side note the fact that since that time, we have recognized that there is more to life than just correcting a skeletal malocclusion for the sake of getting teeth to line up. That you have spent the last 20 years of your life focused on helping to improve the health span of children from a medical perspective, and how developmental imbalances in the growth have found to be hugely impactful on the growth and development and the health and well-being. And from my perspective, my understanding from work done by Peter Bushang at Texas A&M on posture, redefining the work that was done by Bjork on Roberts of the University of Indiana, who did basic science research to confirm that the genetic component of influence finishes at 18 months, and that environmental factors are hugely important from 18 months onward once the Ds erupt into place. That functional appliances, as confirmed by Peter Bushang, actually don't work, and that it's posture and true mandibular rotation that determines the eventual chin position of the mandible. So although we proved one of our tools as being a complete waste of time, in the last 25 years, we've learned that airway disorders, general health and well-being, the state of anxiety and mental status and neurocognitive behavior of children are immensely influenced by disease that is not checked in the early years. So after that kind of long-winded introduction, I just wanted your thoughts on what has brought you the confidence to be able to teach now that we have to treat before 6.
First of all, Keon said children 4 to 10 years old. And that to me is like saying adults 20 to 110 years old. That span is too large. And really, he did his best. I'm not criticizing him, but that's really how the world looks at it. Before 10 in the orthodontic world, as we were directed, as you put it, Simon, that, you don't get in before 10. That's insane. And Bushang and everybody shows functional appliances don't work. Well, they don't work the way that they're diagnosing, assessing risk, and when they're applying them. Of course they don't work. I would agree, I don't defend that. We have to start changing morphology, but we first need to put what I call a new angle. Angle as in angle, class 1, 2, and 3. I call a new angle class 4, bimaxillary retrusion. And Simon, well over half of the children that we're treating class 1, 2, or 3. And thank you, Bill Hang, for introducing us to McNamara's 1982 paper, that most class 2 malocclusions are not just mandibular retrusion, they're also maxillary retrusion. Nobody talks about it anymore. Every adult that could benefit from a maxillomandibular advancement surgery, what by nature, by definition, must be their pre-surgical diagnosis. If maxillomandibular advancement solves the problem, the skeletal problem is maxillomandibular retrusion. And we know
Absolutely.
it begins in early childhood, but it's subtle. Let's let it get more complex. That is the orthodontic paradigm. Let's let it become more complex, and then let's treat it. What disease, what organ system in the human body would be allowed to go from pre-stage 1 disease to stage 4 before we get in and start, I don't need to go there. You understand it. I hope
Well,
other people will make that analogy.
Peter Bushang and Wang's work in 2009 verified using the historical database from the growth studies in the 1900s that malocclusions are well established by 5, and that any vertical component, which is that dual retrusive nature of growth, is usually locked into place, and 2/3 to 3/4 of them never improve on their own.
And there's lots of pre-World War II scientific clinicians that understood a distal step molar upon eruption of the primary second molars. All right. If you have a distal step molar, guess what? You have a class 2 skeletal dental malocclusion for life. It never self-corrects, never, and is always associated with maxillary transverse deficiency. I can defend that. Argue with me on that, please. It is a fact. And it has been completely the orthodontic profession. They've known this. They're the ones who taught it to us. Distal step molar never becomes anything but a class 2 skeletal. And now that we understand the comorbid association of class 2 skeletal retrusion and maxillary transverse deficiency, they're always together. They will either obviously or later on, not obviously, but it's going to be a comorbidity with sleep and breathing problems, which is a
Absolutely.
comorbidity with cardiac, neurological, hearing, seeing. Forget it. Just get off. If you don't want to do this, just understand, please assess risk. The American Dental Association says it's incumbent upon anybody who sees children, whether it's an orthodontist, pediatric dentist, or a primary care general dentist like Simon and many others. They're the ones who are doing most of the work. You must assess risk. It is incumbent upon everybody to assess risk and inform the parents. This child will be or already is at risk for sleep and breathing disorders, and they will be comorbid with all kinds of systemic illnesses. Just make them aware of it. It doesn't mean your kid is going to have ADD. They might, but it's just you make them aware of it. You don't have to treat. Please, people do not, everyone listening here today, it's not your responsibility to treat these kids. It's your responsibility to inform the parents. This is a risk factor, and it's in the literature. I've submitted 12 articles. Please pay attention to them.